Dex infections, meningococcemia caused by N. meningitis. Typical picture as it's characterized by DIC petechiae or papulopustulosis in palms and soles, especially in more severe cases. Second most common pathogen in this age group after S. pneumonia. If the duration between symptoms as recurrent fever is mentioned and a long duration is anticipated, point at 2 weeks, recurrent meningococcemia should be considered and evaluation for complement deficiency should be done. Also, consider herpes encephalitis, meningoencephalitis. Other bacterial meningitis may cause similar symptoms, but they're less associated with this type of rash and DIC. Atypical chickenpox with multi-organ involvement. Sepsis could be caused by viruses, fungi, or bacteria. Toxic shock syndrome due to multi-organ failure and/or DIC. Rare diseases in EU, viral hemorrhagic fever, dengue, yellow fever, and Ebola. Rocky Mountain spotted fever, characteristic petechial rash, particularly on the extremities. Kawasaki disease, the diagnosis of incomplete atypical, KD, which occurs more commonly in infants, is made when fever is present for at least 5 days, even if only 2 or 3 clinical criteria are present, particularly in the presence of coronary artery aneurysms. Nelson's PDF, page 442, DDX section. Mentioned in the other doc, but I think this should be mentioned last after all infections. Acute leukemia, although unlikely, but should be considered through basic initial tests. Drug reactions, SJS or 10, main causes are TMP, SMX, steroids, antiepileptics, piroxicam, CMV, herpes, myco, pneumonia. Brain lesions, mainly abscess. Diagnostics, firstly, a detailed history must be obtained, including delivery details and complications, familial history with emphasis on primary immunodeficiency disorders, travel and exposure history, vaccinations assessment, and medications history. Assess the child on WHO growth charts, obtain GCS and sepsis scores, SOFA, Phoenix sepsis score. A vascular access should be established. 2 blood samples for culture, a blood sample for CBC with morpho, coagulation factors, BMP electrolytes, renal function, acid base, inflammatory markers, CRP, ESR, lactate, hepatobiliary function, sample for antigen and PCR testing, ready kits. LP and CSF culture, antigen and PCR testing, ready kits analysis unless CI, including intracranial pressure, hypertension. If new onset seizures, deterioration, lack of improvement, or other CNS alarming signs are observed, a CT scan will be necessary and it may be followed by MRI. Further, if Kawasaki is suspected, other results non-indicative of any other diseases, an echocardiography should be performed then and 6 weeks later if diagnosis is confirmed. Troponin, HT, proBNP levels if PE, echo, and/or ECG reveal any abnormalities. A head CT scan should be obtained in patients with GCS of 14 or less or other signs of altered mental status, external evidence of head trauma or a history of loss of consciousness, vomiting, or severe mechanism of injury. Page 208, PDF lab and imaging studies. Treatment: vancomycin, acyclovir, valacyclovir, IV, IG plus aspirin, GCS, infliximab, supported as per need. Acute diarrhea in a 3-year-old child can be caused by various factors, including infectious agents, dietary issues, and other medical conditions. Here are some common causes to consider when suggesting a diagnosis. 1. Infectious causes. Viral infections. Rotavirus, most common in children, norovirus, adenovirus. Bacterial infections. Escherichia coli, Salmonella, Shigella, Campylobacter, Clostridium difficile. Parasitic infections. Giardia lamblia, Cryptosporidium. 2. Dietary and nutritional causes. Lactose intolerance. Difficulty digesting lactose, which is common in milk and other dairy products. Food allergies. Allergies to foods such as peanuts, eggs, or soy can cause diarrhea. Food poisoning. Ingestion of contaminated food with bacteria or toxins. 3. Functional gastrointestinal disorders. Toddler's diarrhea, a common condition in young children characterized by loose stools but generally well health. Irritable bowel syndrome, IBS, less common in young children, but a possibility if symptoms are chronic. 4. Medication-induced. Diarrhea can be a side effect of antibiotics or other medications. 5. Other medical conditions, celiac disease, an immune reaction to eating gluten, a protein found in wheat, barley, and rye. Inflammatory bowel disease, IBD, includes Crohn's disease and ulcerative colitis, though rare in this age group. Diagnostic approach, medical history and physical examination to check for signs of dehydration, abdominal pain, fever, and other related symptoms. Stool tests to identify any infectious agents like bacteria, viruses, or parasites. Dietary review and elimination diets to assess for food intolerances or allergies. Blood tests to check for signs of inflammation or anemia. Immediate attention to hydration and electrolyte balance is crucial while the underlying cause is being diagnosed and treated. Chronic diarrhea in children. Definition: excessive daily stool liquid volume, 10 milliliters stool kilogram body weight, day. Stool texture, volume, and frequency help to characterize the episode of diarrhea. Causes: post-infectious secondary lactase deficiency, lactose intolerance, irritable bowel syndrome, celiac disease, inflammatory bowel disease, food allergies, cystic fibrosis, giardiasis, Hirschsprung, factitious, hyperthyroidism. Diagnostic approach: comprehensive history taking and physical examination. Childbirth details and complications, travel, medications, dietary, personal, and family illness history. Exposure to sick contacts, onset and duration of symptoms, frequency and consistency of stools, presence of blood or mucus in stools, associated symptoms, e.g. fever, vomiting. Blood tests can help aid the diagnosis, including CBC, BMP, inflammatory markers, specific disease marker, IgA-TGA for celiac, antigen for pathogens. Stool, culture PCR microscopy for ova and parasites, lactose breath test, abdominal US XR, endoscopy, chloride sweat test, CT, barium studies. Table 126.9. Differential Dinkyled Atorrhea Infilt Diagnosis Associated 126.9. Common gastroenteritis, systemic infection, food poisoning, antibiotic associated, systemic infection, antibiotic associated. antibiotic associated. Rare primary disaccharides deficiency, hyperthyroidism, FPAS appendicitis, Hirschsprung toxic colitis, adrenogenital syndrome, opiate withdrawal, neonate, common, post-infectious secondary lactase deficiency, post-infectious secondary lactase deficiency, irritable bowel syndrome, cow's milk soy protein intolerance, lactose intolerance, inflammatory bowel disease, chronic nonspecific diarrhea of infancy, irritable bowel syndrome, lactose intolerance, toddler's diarrhea, celiac disease, giardiasis, celiac disease, lactose intolerance, laxative abuse, anorexia nervosa, cystic fibrosis, giardiasis, celiac disease, Hirschsprung, secretory tumors, factitious primary bowel tumor, hyperthyroidism, AIDS enteropathy, Addison disease, parasitic infections, rare primary immune defects, acquired immune defects, familial villus atrophy, secretory tumors, pseudoobstruction, congenital chloride diarrhea, factitious acrodermatitis enteropathica, AIDS enteropathy, lymphangiectasia, eosinophilic gastroenteritis, abetalipoproteinemia, eosinophilic gastroenteritis, short bowel syndrome, autoimmune enteropathy, IPEX-like disorders, malabsorption syndromes. Gastroenteritis includes viral, rotavirus, norovirus, astrovirus, and bacterial, Salmonella, Shigella, Escherichia coli, Clostridium difficile, Yersinia, Campylobacter, other agents. FPS, food protein-induced enterocolitis syndrome, IPEX, immune dysregulation, polyendocrinopathy, enteropathy, X-linked. Causes of vomiting in a school-aged child. In older children with acute vomiting, viruses and food poisoning are common. Other infections, especially streptococcal pharyngitis, urinary tract infections, and otitis media, commonly result in vomiting. When vomiting is chronic, central nervous system (CNS) causes increased intracranial pressure, migraine must be considered. Cyclic vomiting syndrome or abdominal migraine may be the etiology of recurrent vomiting. When abdominal pain or bilious emesis accompanies vomiting, evaluation for bowel obstruction, peptic disorders, and appendicitis must be immediately initiated. Given the frequency of viral gastroenteritis as the etiology, it is important to be alert for unusual features that suggest another diagnosis. Viral gastroenteritis usually is not associated with severe abdominal pain or headache and does not recur at frequent intervals. Page 6 or 6 vomiting syndrome. Intermittent episodes of prolonged nausea and vomiting with healthy periods in between. Occur at any age but is diagnosed most frequently in preschool to school-age children. Thought to be a migraine variant, many patients have a positive family history of migraines, and some with CVS will eventually develop migraine headaches. Triggers to an episode often include viral illnesses, lack of sleep, stressful or exciting events, holidays, birthdays, vacations, physical exhaustion, and menses. Often start in the early morning hours. Episodes are similar to each other in timing and duration. Repetitive vomiting can last hours to days. Patients can also have abdominal pain, diarrhea, and headaches. Those affected are typically pale, listless, and prefer to be left alone. Photo or phonophobia. Additionally, DKA should be considered. Pellagra or niacin B3 disease is characterized by weakness, lassitude, dermatitis, photosensitivity, inflammation of mucous membranes, diarrhea, vomiting, dysphagia. B6 deficiency, hypochromic microcytic anemia, vomiting, diarrhea, failure to thrive, listlessness, hyperirritability, and seizure. Iron, zinc deficiency, hypokalemia, metabolic alkalosis, hypernatremia, tests of renal function, complete blood count, amylase, lipase, and liver function tests. Testing stool for occult blood if ulcer disease or severe esophagitis is suspected. Ultrasound is useful to look for pyloric stenosis, gallstones, renal stones, hydronephrosis, biliary obstruction, pancreatitis, malrotation, intussusception, and other anatomic abnormalities. CT may be indicated to rule out appendicitis or to observe structures that cannot be visualized well by ultrasound. Barium studies can show obstructive or inflammatory lesions of the gut and can be therapeutic, as in the use of contrast enemas for intussusception. Table 126.8 Differential Diagnosis and Historical Features of Vomiting. Historical clues. Table 126.8 Viral gastroenteritis, fever, diarrhea, sudden onset, absence of pain. Gastroesophageal reflux, effortless, not preceded by nausea. Hepatitis, jaundice, history of exposure, extragastric intestinal infections, otitis media, fever, ear pain, urinary tract infection, dysuria, unusual urine odor, frequency, incontinence, pneumonia, cough, fever, chest discomfort. Milk or soy protein intolerance, infants, associated with particular formula or food, blood in stools, other food allergy, older children. FPIE, acute onset vomiting, diarrhea, dehydration, shock. Peptic ulcer or gastritis, epigastric pain, blood or coffee ground material in emesis, pain relieved by acid blockade, appendicitis, fever, abdominal pain migrating to the right lower quadrant, tenderness, pancreatitis, severe epigastric abdominal pain. Anatomic obstruction, intestinal atresia, neonate, usually bilious, polyhydramnios. Midgut malrotation, pain, bilious vomiting, GI bleeding, shock, intussusception, colicky pain, lethargy, vomiting, current jelly stools, mass occasionally. Duplication cysts, colic, mass, pyloric stenosis, non-bilious vomiting, postprandial, 4-mo-old, hunger, progressive weight loss, Hirschsprung disease, abdominal distension, lack of stools, bacterial gastroenteritis, fever, often with bloody diarrhea, hydrocephalus, large head, altered mental status, bulging fontanelles, meningitis, fever, stiff neck, migraine syndrome, attacks scattered in time, relieved by sleep, headache, cyclic vomiting syndrome, similar to migraine, usually no headache, brain tumor, morning vomiting, accelerating over time, headache, diplopia, motion sickness, associated with travel in vehicle, labyrinthitis, vertigo. Metabolic disease, presentation early in life, worsens when catabolic or exposure to substrate. Pregnancy, morning sexually active, cessation of menses, drug reaction or side effect associated with increased dose or new medication. Cancer chemotherapy, temporarily related to administration of chemotherapeutic drugs. Eosinophilic esophagitis may have dysphagia or abdominal pain, CNS, central nervous system, FPIS, food protein-induced enterocolitis syndrome, GI, gastrointestinal. Recurrent icteric sclera in a 15-year-old. Due to high levels of serum bilirubin, 2-3 milligrams per deciliters, infectious mononucleosis, EBV, CMV, hepatitis, cholecystitis, cholelithiasis. Gilbert disease, most common inherited hyperbilirubinemia. Prevalence is 3 to 7% in the US, AR. Asymptomatic or nonspecific symptoms such as fatigue and loss of appetite. Transient, usually mild jaundice, varying from mild scleral jaundice to general jaundice. No treatment required. Crigler-Najjar syndrome. UDP glucuronosyl transferase is almost completely absent, AR. Persistent jaundice, kernicterus. Treatments include phototherapy, plasmapheresis, cure LTX, liver transplant. Long-term parenteral nutrition, drug-induced, porphyria cutanea tarda, PCT, galactosemia, pyloric stenosis, Wilson's disease, a rare inherited disorder that causes copper to accumulate in the liver, brain, and other vital organs, which can also lead to hepatic dysfunction and jaundice. Diagnostic procedures. Physical examination and history taking will help guide the diagnostic procedure, including inquiries about jaundice episodes, abdominal pain, fever, changes in stool or urine color, and familial diseases. CBC, complete blood count, kidney function, liver function tests, ALP, AST, ALT, GT, bilirubin, to evaluate the overall health and functioning of the liver. Hemolysis workup, including reticulocyte count, LDH, haptoglobin levels, and a Coombs test to rule out hemolytic anemia. Urinalysis, blood culture, stool analysis to detect any ongoing infection or liver disease manifestations. PCR or antigen testing for diseases like EBV and CMV to identify infectious causes of jaundice. Imaging tests, USG, ultrasound sonography, CT, computed tomography, MRCP, magnetic resonance cholangiopancreatography to visualize the liver and biliary tract for any anatomical anomalies. Genetic testing may be necessary, especially when normal liver enzymes suggest conditions like Gilbert's or Crigler-Najjar syndrome. Proper evaluation and workup are crucial for differentiating among these conditions and determining the appropriate management. Due to the orientation and quality of the image, it's difficult to read and transcribe the entire table accurately. However, here is an attempt to provide what is discernible. Figure 130-1 Differential diagnosis of jaundice in childhood, neonates, infants, children. Unconjugated hyperbilirubinemia. Conjugated hyperbilirubinemia. Autoimmune. Hemolysis and related conditions. Metabolic, idiopathic neonatal hepatitis, ABO and RH incompatibility, progressive familial intrahepatic cholestasis, breast milk jaundice, Alagille syndrome, hematomas, bruising, A1 antitrypsin deficiency, Crigler-Najjar syndrome, cystic fibrosis, G6PD deficiency, galactosemia, hereditary spherocytosis, tyrosinemia, physiologic jaundice, Wilson's disease, pyruvate kinase deficiency, sickle cell disease, spherocytosis, obstructive causes, toxic, chronic recurrent, biliary atresia, total parenteral nutrition, sclerosing cholangitis, choledochal cyst, drug-induced, e.g. erythromycin estolate, inspissated bile syndrome, intestinal atresia, midgut volvulus, tumor cyst, infectious post-transfused drug-induced newborn, CMV, hepatitis B, C, EBV, HIV, hepatitis A, syphilis, sepsis, toxoplasmosis, urinary tract infection, metabolic, RBC enzyme defects, albumin-bound blood, congenital hypothyroidism, G6PD deficiency, Crigler-Najjar syndrome type 2, cystic fibrosis, pyruvate kinase deficiency, Lucy-Driscoll syndrome, galactosemia, Niemann-Pick disease, tyrosinemia. Note, this table is incomplete and the items listed under each category may not include all conditions due to the image quality. Diagnosis in an 11-year-old with suspected inflammatory bowel disease. Blood, anemia, leukocytosis, thrombocytosis, BMP, ESR, CRP, liver, GGT, iron, electrolytes, vitamins, paranuclear ANCA. Stool, fecal calprotectin and lactoferrin, culture and assays. Endoscopy, upper endoscopy, colonoscopy, video capsule endoscopy. Imaging, upper GI series with SBFT, CTE, MRE, US for DDX. PIENCA is important, especially for UC, while IgA and IgG against ASCA is associated with Crohn's. However, still not recommended to be used for differentiation purposes. Endoscopy must be performed if IBD is suspected. A full colonoscopy is always indicated. As a result, going directly to colonoscopy is more cost-effective in many cases. It is mandatory to exclude infectious disease by performing blood and stool cultures and toxin tests for Clostridium difficile. Colonoscopy with biopsy is the most valuable procedure in the evaluation of the patient with inflammatory bowel disease. When possible, the whole colon and terminal ileum should be assessed even in UC, as pancolitis may lead to colonic regurgitation of contents to the ileum. At least 2 biopsies should be obtained from different inflammatory regions. Endoscopy can't reach the jejunum and ileum. Therefore, suspicion of Crohn's disease must include capsule endoscopy, upper GI series with SBFT, CTE, or MRE. In all children with ulcerative colitis, UC, except those with sepsis or emergency unit, imaging studies should be undertaken only if they are necessary after endoscopy evaluation is complete. The results of previous tests plus PCDAI, PUKI, and Truelove-Witz scores will determine the severity. You see Crohn's inflammation that is first evident in the rectum and that proximally extends in a contiguous fashion, sparing of the rectal mucosa, and non-contiguous or skip lesions, erythematous, friable, and granular mucosa. These are perianal disease, aphthous ulceration. No pathognomonic biopsy findings. Granulomas at 30%. Polymorphonuclear leukocytes near the base of the crypts and cryptitis. Edema, inflammation, mononuclear and polymorphonuclear. Lymphocytes, eosinophils, and mast cells in acute UC. Cryptitis and crypt abscesses. Architectural crypt changes. Mucosal plus submucosal. Transmural extension of the inflammation. Table 129.2 Diagnostic Studies for Inflammatory Bowel Disease Interpretation. Blood test, CBC with WBC differential. Anemia, elevated platelets suggest IBD. ESR, elevated in many but not all IBD patients. C-reactive protein, elevated in many but not all IBD patients. Albumin, may be low in IBD due to fecal loss. ASCA, found in about 50% of CD patients and few UC patients. Atypical P-ANCA, found in most UC patients and few CD patients. Anti-OMP-C, found in some UC and CD patients, rare in non-IBD. Anti-C-BIRE1, found in about 50% of CD patients. Fecal calprotectin and lactoferrin, elevated in IBD and can differentiate from functional disorders. Imaging studies, upper GI series with SBFT, evaluate for ileal and jejunal CD. CT scan used to detect abscess, small bowel involvement. Magnetic resonance enterography, used to detect bowel thickening, inflammation, and strictures, as well as abscesses and fistulas. Upper endoscopy, evaluate for CD of esophagus, stomach, and duodenum. Obtain tissue for histologic diagnosis. Colonoscopy, show presence or absence of colitis and terminal ileal CD. Obtain tissue for histology. Video capsule endoscopy, emerging role in diagnosis of small bowel CD, more sensitive than upper GI series with SBFT. Anti-OMP-C, antibody to outer membrane protein C, ASCA, anti-Saccharomyces cerevisiae antibody, atypical PENC, atypical paranuclear staining by antineutrophil cytoplasmic antibody, CBC, complete blood count, CD, Crohn's disease, CT, computed tomography, ESR, erythrocyte sedimentation rate, GI, gastrointestinal, IBD, inflammatory bowel disease, SBFT, small bowel follow-through, UC, ulcerative colitis, WBC, white blood cell. Causes of pericardial fluid: viral, bacterial, fungal pericarditis, pneumonia, collagen disease, neoplastic and after medications, trauma and iatrogenic, metabolic, hypothyroidism, uremia. Any organ or system can be injured by toxic accumulation of any of the metabolites involved in inborn errors. Diagnosed through echocardiography, 50 milliliters of fluid in the pericardium. ECG will reveal global ST elevation, reduced QRS voltage, or electrical alternance, variable QRS amplitude. Table 148.1, etiology of pericarditis and pericardial effusion. Idiopathic infectious agents, collagen vascular inflammatory and granulomatous diseases. PROMOC, traumatic, group A streptococci. Bacterial, rheumatic feintusion, cardiobulbar trauma, group A streptococci. Systemic lupus erythematosus, idiopathic and drug-induced trauma, Staphylococcus aureus, rheumatoid arthritis, postpericardiotomy syndrome, pneumococcus, meningococcus, Kawasaki disease, radiation, Haemophilus influenza, scleroderma, Mycobacterium tuberculosis, mixed connective tissue disease, pleural disease, viral inflammatory bowel disease, pneumonia, Coxsackie virus, group AB, sarcoidosis, aortic aneurysm, dissecting, echovirus, vasculitis, mumps, hypothyroidism, influenza, uremia, Epstein-Barr pericardium, cytomegalovirus, neoplastic, primary. Histoplasma capsulatum, contiguous lymphoma, coccidioides immitis, metastatic blastomyces dermatitis, infiltrative leukemia, candida, other etiologic disorders factors, drug reaction. After myocardial infarction, thalassemia, central venous catheter perforation, heart failure, hemorrhage, coagulopathy, infectious or immune complex. Common viral pericarditis or myopericarditis is probably the most common cause of acute pericarditis in a previously normal host. Diagnosis of chest pain in a child, careful and extensive history in PE. Birth condition, any complications, any surgeries or medications, any history of other cardiovascular, muscular, respiratory, and psychiatric symptoms or illnesses. Familial history of diseases, genetic mutations, and SCD. PE should be comprehensive and start with assessing the vitals and the heart for any murmurs, jugular vein, carotid assessment. Assess the airway, Malampati score, then RR and breathing sounds. Muscle tone and strength should be assessed, and skin for rash, S for DIC. Table 1141.1, differential diagnosis of pediatric chest pain, common, uncommon, rare. Musculoskeletal, cardiac, costochondritis, ischemia, coronary artery abnormalities, severe AS or PS, COCM, cocaine, trauma or muscle overuse strain, infection, inflammation, endocarditis, pericarditis, Kawasaki disease, asthma, often exercise-induced, musculoskeletal, severe cough, abnormalities of rib cage, thoracic spine, pneumonia, Tietze syndrome, gastrointestinal, slipping rib, reflux esophagitis, tumor, psychogenic, pulmonary, anxiety, hyperventilation, pleurisy. Miscellaneous, pneumomediastinum, precordial catch syndrome, texidor twinge, pleural effusion, sickle cell vaso-occlusive crisis, pulmonary embolism, idiopathic gastrointestinal, esophageal foreign body, esophageal spasm, psychogenic, conversion symptoms, somatization disorders, depression, AS, aortic stenosis, HOCM, hypertrophic obstructive cardiomyopathy, PS, pulmonary stenosis. Diagnosis of gallstones in a 10-year-old girl, high BMI obesity, rapid weight loss, systemic disease or psychiatric, chronic hemolysis, sickle cell disease, hemolytic anemia, thalassemia, hereditary spherocytosis, cystic fibrosis, long-term parental nutrition, family history, medications, detailed personal and family history, CBC plus liver plus pancreas, US and X-ray, MRCP, ERCP when necessary. Diagnosis of syncope in children. First episodes without alarming symptoms with normal prodrome do not require further investigation. If the episodes have a significant impact on daily activities, further evaluation may be indicated. An electrocardiogram ECG should be obtained with attention to the QTc and PR interval, orthostatic vitals, anemia, BNP, and glucose should be assessed. AV block, QTc prolongation, sinus bradycardia, WPW, ischemia, Table 140.1, syncope and dizziness, etiology, diagnosis, history, signs, symptoms, description, heart rate, blood pressure, duration, post-syncope, recurrence, neurocardiogenic, vasodepressor, at rest, pallor, nausea, visual changes, brief sinus convulsion at 1 min, residual pallor, sweaty, hot, can recur if child stands, common, other vagal, micturition, post-voiding, pallor, nausea, brief convulsions, rare, pat, 1 min hair grooming, standing getting hair done or ears touched, pallor, nausea, visual changes, lightheaded, brief residual pallor, sweaty, hot, can recur if stands too soon, cough, deglutition, paroxysmal cough, abrupt onset, may not change, 5 min, fatigue or baseline, carotid sinus, tight collar, turned head, vague visual changes, sudden onset, pallor, usually 5 min, fatigue or baseline. Alveolar obstruction, exercise, chest pain, SOB, abrupt during or after exertion, pallor, any duration, fatigue, residual pallor and sweating, pulmonary hypertension, anytime, especially exercise, cyanosis and pallor, FRART, any duration, fatigue, residual cyanosis, myocarditis, post-viral infection, exercise, SOB, chest pain, palpitations, pallor, any duration, fatigue, tumor or mass, recumbent, paroxysmal, SOB plus chest pain, pallor, any duration, baseline, coronary artery disease, exercise, SOB plus chest pain, pallor, any duration, fatigue, chest pain, dysrhythmia, anytime, palpitations plus chest pain, pallor, usually 5 min, fatigue or baseline, plus alveolar left ventricular outflow tract, SOB, shortness of breath, plus with or without, plies with or without. From Louis D.A., Syncope and Dizziness in Klingman, R.N., Practical Strategies in Pediatric Diagnosis and Therapy, Philadelphia, W.B. Saunders, 1996. 4-year-old girl presents to outpatient because of fatigue for 2 to 3 months. Diagnosis: AV block, sinus bradycardia, ECG, hypothyroidism, TSH, FT4, OSA, polysomnography. Dot 42. A 12-year boy accidentally found hypertension 150/80-85 millimeter Hg and a BMI of 90 to 95C. Suggests diagnostics. The BMI of the boy suggests that he is overweight or in the pre-obesity group. Metabolic syndrome should be considered. Criteria for metabolic syndrome: COLIS 3 must be present, i.e., the patient is either diagnosed with or receiving treatment for the condition. Elevated blood glucose, fasting glucose to 100 milligrams per deciliter, elevated blood pressure, systolic 130 millimeter Hg and or diastolic 85 millimeter Hg, elevated triglycerides to 150 milliliter, low HDL-C, men 40 milligrams per deciliter, women 50 milligrams per deciliter. Abdominal obesity, men waist circumference 102 centimeters or 40 in, women waist circumference 88 centimeters or 35 in. Abdominal obesity, i.e. accumulation of fat in visceral tissue, is strongly associated with an atherogenic and hyperglycemic state. Blood pressure cannot be interpreted as children 13 IO, required to be assessed in percentiles, and more measurements are needed to establish a diagnosis of hypertension. Diagnosis of acute pyelonephritis, physical examination and exhaustive history taking, history of UTI or other infections, presence of congenital abnormalities, renal and post-renal disease, failure to thrive, fever, poor feeding, diarrhea, urgency, dysuria, frequency, and abdominal or back pain. The presence of UTI should be suspected in all infants and young children with unexplained fever and in patients of all ages with fever and congenital anomalies of the urinary tract. Triad, lumbar pain, fever, NV, plus, gold flam sign, blood, CBC, CRP, ESR lactates, culture from 2 different sites, urine, analysis, hematuria, pyuria, albuminuria, pH, glucose, nitrites, ketones, urine sediment, leukocyte esterase, imaging, not always necessary, US initially and voiding cystourethropy if recurrent UTIs, abnormal USG or VUR is suspected. Technetium 99M dimer haptosuccinic acid DMSA scan can identify acute pyelonephritis and is most useful to define renal scarring as a late effect of UTI. Diagnosis of proteinuria may appear as foamy urine, 150 milligrams per day protein in urine dipstick to rule out transient proteinuria, sulfosalicylic acid test added to urine to measure total urine proteins, 24H urine collection, urine sediment, rule out glomerular disease. Diagnostics, read page 2883, combined norms of physiologic proteinuria, 4 milligrams per milligram tristan or 5 milligrams per kilograms per 24H, or 100 to 150 milligrams per day. Non-functional proteinuria, high fever after vigorous exercise, the cold, stress, cardiac insufficiency. Orthostatic proteinuria, only on standing, hemodynamic etiology, 60% of all cases of proteinuria in children. Overflow proteinuria, due to presence in plasma of an excess concentration of small molecular protein filtered through normal glomeruli in high amounts exceeding the tubule's capacity for reabsorption. 1. Hemoglobin, hemolytic anemia. 2. Myoglobin, rhabdomyolysis. 3. Bence-Jones protein, plasmacytoma. 4. Amylase, pancreatitis. 5 and after infusion of plasma or albumins. Classification of proteinuria, pathologic, glomerular proteinuria. 1. Destruction of glomeruli, glomerulonephritis. 2. Loss of negative charge of basement membrane, minimal change disease. Tubular pathologic proteinuria. Causes: inherited cystinosis, Wilson disease, dent disease, galactosemia. Acquired interstitial nephritis, acute tubular necrosis, toxic injury of tubules, analgesics, antibiotics, chemotherapeutics, e.g. cisplatin, ifosfamide, heavy metals, e.g. mercury, lead. Postrenal proteinuria, due to lesion of urinary tract, infection, nephrolithiasis, schistosomiasis tumors, characterized by a protein pattern identical to plasma. Diagnosis of hematuria, presence of RBC in urine. Macroscopic hematuria may appear as red urine or dark brown, cola-colored. Suggests non-glomerular damage, e.g. cystitis, urolithiasis, acute pyelonephritis, trauma. Microhematuria doesn't look abnormal in color, but RBC is still present. Suggests damage to glomeruli, nephritic syndrome, characteristic of glomerulonephritis. History, family history, kidney disease, medications. Additional symptoms: dysuria, flank pain, skin changes. Urine dipstick, detects heme. Negative result excludes hematuria, positive doesn't confirm it. Urine sediment, confirm hematuria, 3 RBCs. Most common in children: IgA nephropathy, post-streptococcal glomerulonephritis. Diagnosis of sideropenic anemia in a child, aka iron deficiency anemia. CBC, low HBG, 2SD for age and sex, low HCT, high platelets, reactive from thrombocytosis, RBC, low MCV, microcytic or normal, MCH, mean corpuscular hemoglobin, low or normal. Increased red cell distribution, peripheral blood smear. RBCs have increased zone of central pallor, iron. Low serum ferritin, low serum iron, high serum transferrin. Diagnosis of hemolytic anemia in a child. Symptoms range from asymptomatic to life-threatening hemolytic crisis. Many different types of hemolytic anemias. Coombs test differentiates antibody-mediated plus and non-antibody-mediated minus. Suspect in patients with anemia without obvious cause and lab findings of hemolysis. Anemia, CBC, low HBG, HCT, RBC, MC, mostly normocytic, WBC, elevated. Platelets, low in MAHA, microangiopathic hemolytic anemia. Iron, usually normal. Hemolysis, no single test, but generally low haptoglobin, high LDH, high indirect bilirubin. Peripheral blood smear abnormalities, e.g. high reticulocytes, schistocytes, spherocytes. Urinalysis abnormalities, e.g. hemoglobinuria. Coombs test. Diagnosis of acute immune thrombocytopenia in a child may be primary or secondary, commonly self-limiting following viral infection, most patients asymptomatic, sometimes present with minor mucocutaneous bleeding, petechiae, purpura, epistaxis, or rarely severe bleeding. Diagnosis of exclusions: low platelet count with no other abnormalities. Bleeding time may be prolonged, but coagulation panel usually normal. If atypical case or diagnostic uncertainty, bone marrow biopsy. Diagnosis of hemophilia in a child. Blood clotting disorders, varied based on which clotting factor is deficient, all result in impaired secondary hemostasis, increased APTT, hemarthrosis. Patient and family history, bleeding. Genetic testing, screening, prothrombin time, normal. Platelet count, normal. Activated partial thromboplastin time, APTT, usually prolonged mixing study, patient's plasma mixed with normal plasma. If mixing study positive, do quantitative assessment of factor activity levels. Diagnosis of Schindlein-Hennig purpura, clinical diagnosis, purpura, arthralgia, abdominal pain, renal involvement. Laboratory studies to identify organ involvement and exclude DDX, CBC, normal platelet count, HBG if GI bleeding, creatinine and or BUN, coagulation, usually normal, urinalysis, hematuria, proteinuria, biopsy to confirm diagnosis and atypical presentation. When to suspect malignant disease in a child, in patients with suggestive clinical findings, also dependent on localization of malignancy, pain, lymphadenopathy, fatigue, weight loss, night sweats, loss of appetite, hepatosplenomegaly, anemia, headaches, visual impairment, leukocoria. Most common childhood malignancies: retinoblastoma, 12 to 14 meter, leukocoria, strabismus, blindness, Wilms tumor, neuroblastoma, most common congenital malignancy, mostly infants, osteosarcoma in teenagers, hepatoblastoma, 2 years, loss of appetite, weight loss, ascites, jaundice, palpable tumor. When to suspect acute leukemia in a child, suggest a diagnosis. Suspect in patients with suggestive clinical or laboratory findings. Clinical: fever, painless lymphadenopathy, signs of anemia, thrombocytopenia, immunocompromise. With generalized signs: night sweats, unexplained weight loss, fatigue, weakness. Also bone pain, limping, or refusal to bear weight. Laboratory: CBC, WBC may be variable. Platelets: mild to severe thrombocytopenia, hemoglobin, usually anemia. Immature WBC on peripheral blood smear. Metabolic panel, often abnormal due to increased cell lysis. Na, K, Ca, pH may all be hyper or hypo. LDH, uric acid coagulation studies show coagulopathy. Histopathological assessment: blasts in bone marrow, 20% lymphoblasts, smaller size, large irregular nuclei. Immunophenotype: genetic studies, e.g. Philadelphia translocation, 5% children. Differential diagnosis of bone pain in a child: growing pain, osteosarcoma typically hurts at night, asymmetric, or Ewing sarcoma, but more common in second decade. Trauma, stress fractures, osteomyelitis, mostly S. aureus following trauma. Sickle cell disease, juvenile idiopathic arthritis. Differential diagnosis of cough in a child: pulmonary, bronchitis, bronchiolitis, pertussis, croup, pneumonia, foreign body aspiration, asthma, cystic fibrosis, pulmonary edema, psychogenic, drug-induced, ACE-I, PPI, GERD. Diagnosis of cystic fibrosis: autosomal recessive, more common in Europeans, based on clinical findings and evidence of CFTR protein dysfunction, CF transmembrane conductance regulator. All newborns are screened for cystic fibrosis, so diagnosis should be early on. Evidence of CFTR protein dysfunction: 2 sweat chloride tests with chloride 160 millimole per liter tried, 2 CF causing CFTR gene mutations, and a sweat chloride test 30 millimole per liter, genetic testing. Nasal potential difference test, positive abnormal result. Diagnosis in a child with pleural fluid: excess pleural fluid, pleural effusion. Small pleural effusion, often asymptomatic. Symptoms: dyspnea, hypoxia, pleuritic chest pain, sharp retrosternal, dry non-productive cough. Symptoms of underlying disease, e.g. left-sided heart failure, PE, asymmetric expansion on affected side, reduced tactile fremetus. Auscultation: faint or absent breath sounds over area of effusion, pleural friction rub. Percussion. Diagnosis: CXR, unilateral blunting of costophrenic angle, meniscus-shaped margin. In large effusions, complete opacification of lung, mediastinal shift, tracheal deviation away from effusion, USG, similar to FAST for quick assessment. Diagnostic thoracentesis in certain cases, e.g. fever, chest pain. Causes: congestive heart failure, hepatic cirrhosis, nephrotic syndrome, chronic kidney disease, infection, pneumonia, tuberculosis, malignancies, lung cancer, lymphoma, pulmonary embolism, SLE, vasculitis, trauma, hemothorax. Criteria for diagnosis of type 1 diabetes mellitus in a child: random blood glucose 202 milligrams per day in patients with symptoms, polydipsia, polyuria, unexplained weight loss, two abnormal test results for hyperglycemia in asymptomatic individuals. Oral glucose tolerance test. Amount depends on child's body weight after 1 hour at 200 milligrams per day. Fasting glucose 126 milligrams per day. Glycated hemoglobin, HbA1c 6.5 for over 8 to 12 weeks. Diagnosis of tuberculosis in a child. Active. Confirmation of tuberculosis bacilli in sputum samples most common. Obtain 3 samples. Induced sputum. Gastric lavage. Bronchoalveolar lavage. Culture is gold standard diagnostic test. Also gives info on drug susceptibility. Active TB. CXR. Consolidations. Gon complexes. Pleural effusion. Normal imaging doesn't rule out TB. Latent. Immune response to M, tuberculosis antigens with no signs of active infection, asymptomatic and not contagious. IGRA, interferon Y release assay, preferred to TST, especially in those who had BCG, results in 24H. No difference between active and latent TB. Tuberculin skin test, MANTU, no difference between active and latent TB. False positives from BCG vaccine. Preferred test in children 5 years. Positive and high in duration, depends on patient, generally 50 millimeter. Further management is CXR. Differential diagnosis of abdominal tumor in a child: palpable mass in abdomen, hernia, umbilical, inguinal, impacted feces in constipation or other intestinal obstruction, pyloric stenosis, olive-shaped mass in abdomen, but this is more for infants than for children. Hydronephrosis, confirmed abdominal tumor, neuroblastoma, nephroblastoma, Wilms tumor, second most common intra-abdominal malignancy in PEDS. Leukemia, i.e. kidney involvement, hepatoblastoma. Turner syndrome lists the signs and suggests diagnostics: female karyotype, primary ovarian insufficiency, delayed puberty, primary amenorrhea. Cystic hygroma, congenital malformation, presents in infancy or early childhood, lymph-filled swelling in posterior triangle of neck associated with Turner. Lymphedema of hands and feet in neonatal period. Short stature, broad chest, widely spaced nipples, webbed neck. Cubitus valgus, elbow deformity, higher angle when arm is extended. Typical of Turner, but maybe something else. Short fourth metacarpals, metatarsals, nail dysplasia, high arched palate, low set posterior hairline. Diagnostics. Clinical presentation: hypergonadotropic hypogonadism, low estrogen, low androgens, high FSH and LH. Karyotype, confirmatory test.